but they pitched against a air vice marshal. And organizers are so mischievous, they brought both of us together in a same flight, in consecutive seats, and in the hotel just opposite to each other. They want the debate start from yesterday. Okay, actually my aggression is against the disease itself. Exercise. So much importance is given on exercise. See the two articles, meta-analysis of this decade. The plus one, there is very low evidence that combination of exercise and educational intervention improve physical activity. And low evidence was observed for combination therapy reducing pain. What about the Lancet Rheumatology article? There was evidence of a small positive overall effect of therapeutic exercise on pain and physical function. However, this effect is of questionable clinical importance, particularly in medium and long term. But both the articles say it is better than zero, so we should continue advising patients of osteoarthritis for exercise. Better than none. So do we have anything more? Are we missing something? I started digging our old articles, and what I find, 1979, ARD, they compared 100 rheumatoid arthritis patients with 100 osteoarthritis patients. And see, in 1979 they said it is not a wear and tear disease. It is inflammation that is driving the disease. And why we are doing debate now, after nearly 50 years? Another ARD gem, 2006, one rheumatologist, professor of medicine in Vienna, Austria, he himself treated himself with 50 milligram of corticosteroids to relieve pain. He experimented upon himself. He got instant relief. Then he stopped, pain came back. Then he started taking adalimumab. After 6 months, see, BMOs are gone and cartilages has regenerated on the right side. 6 months after that, it works. So, if we target inflammation, we shall not do a bad thing. Recap of definition of osteoarthritis by Warsi. No mention of degeneration. Degeneration is part of life. Everybody is getting degenerated. So why osteoarthritis you should term degeneration, degenerative disease? It is a primary disease, they have said. And inflammation is the middle of its pathogenesis. The maladaptive repair and the deformities, they are part of the inflammatory pathway. Side by side, repair process and inflammation are going. So target the inflammation, you will get better repair. This article is very good. The first paragraph, they have said, inflammation is everywhere. In the earlier way, in the later advanced stage way, in every phenotype. What you have termed phenotype of low repair, elderly persons without any visible swelling, those people are also having synovial inflammation if you see properly by MRI or by other means. Actually, this inflammation goes hand in hand with the conventional risk factors like trauma, aging, or obesity. It is mechanoinflammation. Obesity is giving too much importance. How obesity increases the osteoarthritis, starts the osteoarthritis? It is not due to loading, not due to excess weight. Excess weight may play a part, but inflammation is predominant, both systemic or local. There is infiltration of adipose tissue in the joint, in the periarticular tissues, in the muscles. There will be inflammation, there will be fibrosis. Systemically, there will be inflammatory pathways. Patient will not move. Patient will be reluctant to exercise. Effects of exercise. Animal studies, this slide, osteoarthritis cartilage. I took that slide. Low-grade inflammation, both systemic and local. Strength training. What is strength training? You Google, you will find. It is exercise against resistance. Stair climbing, weightlifting. Conventionally, we advise patients not to take much weight or do not climb. But strength training is beneficial. There are multiple studies. Beneficiary for future new health, counteracting long-held assumptions that strength training had adverse effects. Don't ask your patients not to climb stairs. Ask them to climb stairs. If there is mechanical problem, just take care of that. Weightlifting, ask them to take weight if it is beneficial for day-to-day activities. Don't deny them pain relief. Why strength training is beneficial for the patients? Here, this study, strength training shows there are improve in the muscle inflammatory markers. Inflammation goes on in the muscles also. Strength training improves that inflammation, not the muscle strength. Muscle strength will be there, will gain. But how? Does it help the inflammation joint? There will be decrease in the inflammation. And this strength training, by decreasing inflammation, will benefit your patients. Here, another term is being coined. Multiple articles are there, multiple publications are there in last 3 years. It is the first one, 2022. Publication of this is also in 2024. That is new term, muscle inflammation susceptibility. It is long noted that some patients, nearly 30% of patients are not benefited by knee surgery, TKR. Why is that? So there are inflammation, and that inflammation susceptibility in muscle can be determined by genetic studies also in muscle beforehand, before the surgery. So this inflammation involved in the muscle produces weakness of muscle, fibrosis of the muscle, and then the operation fails. In vitro study, I am going to basic science now, from clinical to basic. They have said it is in vitro study of the joint tissues. And see I am going directly to the conclusion that it is the culture media actually in vitro study. They demonstrated that in way all joint tissues might be involved in the progression of synovitis, with a predominant role of synovial membrane itself compared to the joint tissues. In the result section, you see the cytokines are liberated from all joint tissues except infrapatellar pad. Probably they have not examined the adipokines which may be liberated from infrapatellar pad. But see the number of cytokines. Here, 2012, arthritis research therapy. The cytokines, rheumatoid arthritis sera and osteoarthritis synovial fluid. Almost same pattern of inflammation, cytokines. It is an inflammatory arthritis. It may not be that much inflammation if being compared to rheumatoid arthritis, but it is inflammation. The osteoarthritis serum, cytokines in osteoarthritis serum is obviously more than normal person's serum. I think this slide may convince you. Time is short. Neural axis was discussed by one speaker before me, so I'm not going to detail, but the hyperalgesia, the hypersensitization of nervous system, that is mediated by inflammation, inflammatory markers in every step, from synoviocytes to Schwann cells to spinal cord to brain. Everywhere it is inflammatory markers and inflammation that is producing the nociception in a nociplasticity in osteoarthritis patients. So, summary. What we thought, the site of disease, osteoarthritis, cartilage. Now, what we are thinking? Bone, synovium, infrapatellar pad probably are equally important in comparison to cartilage. What we thought, osteoarthritis risk factors, wear and tear, gone. Today is in 2024. Osteoarthritis risk factor, we do not consider wear and tear as a risk factor. We are considering genetics, we are considering systemic inflammation and local inflammation, both type of inflammation in the pathogenesis of osteoarthritis. Obviously, NSAIDs will work, NSAIDs will prevent TKR, not paracetamol, common knowledge. But did you know that tramadol may kill the patients? Probably the second most prescribed drug in osteoarthritis, because simple. Tramadol is not an anti-inflammatory, does not have any anti-inflammatory effect. Two meta-analysis, just see the number of patients. More than 1 lakh on the left side, on the right, 88,000. Future, only one slide for future, TLR4 signaling. TLR4 signaling is coming up. RNA interference by microRNAs, anti-TLR4 antibodies, and small molecules like, this is a small molecule, CAT242. And the inhibitor starting TLR4, last slide.
30 seconds.
TLR4, like curcumin, our curcumin, it benefits by inhibition of TLR4. So this is my conclusion. It should be considered as a primary disease, primary inflammatory disease, and the inflammation along with mechanical factors should be targeted. Thank you.